Dr. John Wright is the lead fetal cardiologist at Birmingham Women's and Children's Hospitals. During this interview, the diagnosis of congenital heart disease, the possible treatment pathways and the risks that may present for the child will be explored. The lifestyle issues and long-term care plans for children with single ventricle heart disease will also be discussed.
With most fetuses that we scan at 20 weeks, we can make a clear diagnosis. Therefore, the plan in our unit would be to repeat a scan at around 34 to 36 weeks, just to dot the I's and cross the T's to make sure that we know subtle changes which may influence how we manage the baby at delivery. If I'm not entirely clear as to all the particular aspects of the heart problem, I may wish to repeat the scan at 2 or 4 weeks later to get a precise diagnosis. One would normally assess the baby within a few hours of birth, but usually we can put a plan in place which the local neonatal team can institute immediately the baby's born, keep the baby stable, and then for the baby to have detailed cardiological assessment within the first day of birth. The other things we're particularly interested in is the anatomy of the arteries to the lung and to the body circulation, because you can get a narrowing in either one of those, and that will influence the postnatal course. The other aspect I look at carefully too is how well is that heart functioning as a pump, and do the valves within the heart leak or not, because those would adversely affect the outcome of the baby. Many people do ask me why this wasn't picked up at 12 weeks. A number of reasons to that is that not all obstetric centres can provide a cardiac scan at 12 weeks, and they do not look at the heart. Those that do, it is very easy to miss the diagnosis because of the technology, and you may not be getting quite precise images that you would get at 20 weeks. Very often with congenital heart disease, this is an isolated problem. The circulation before birth is different than after birth, and you can survive on one pumping chamber in your heart before birth because of those reasons. And if there is nothing else wrong with the baby will develop properly. Even though there is no family history of congenital heart disease, we know that the risk of any couple having a child with a heart problem is about 1%. We don't know exactly why, and we cannot predict which couple will have a child with a heart problem. Perhaps sometime in the years ahead, genetic studies will improve and we will have an answer, but at the moment we don't. We usually find that because the heart works differently before birth, that actually prior to delivery and at delivery, babies with heart problems are at no greater risk from any other baby of dying. So for instance, there could be obstetric complications, placenta previa, placental abruption, but there's no evidence to say that babies with heart problems are at any greater risk. Once the umbilical cord is cut, that's when we have to start treatment for babies with this condition. There are a number of treatment choices available to parents once a diagnosis is made. And in the main, there are 3 choices which parents have. All 3 are very difficult. The first treatment choice would be interruption of the pregnancy, which is possible at any stage. possible but difficult at any stage before delivery. After delivery, the choices are comfort care, that is, not to treat the heart specifically, but to keep the baby comfortable, to not suffer from the consequences of the heart problem. And the third choice is to go down the line of the surgical treatment plan, which will vary from baby to baby. We know that children after birth with a univentricular heart, the heart is not going to function as a pump as well as if they had two pumping chambers. So inevitably, at some stage in the future, the heart will fail as a pump. And I think that the best that we could hope for at the present time is that children in whom a surgical treatment plan has gone very well will probably be looking at transplantation in their early 20s. For some, this will be later, but for some, it will be earlier. I've just given an overview. We do know, however, that for some this will be quite early in childhood, maybe before their 10th birthday. As I said before, most babies with a heart problem do not have another problem, but we do know that 20% of babies born with congenital heart disease have another congenital problem, which may not be apparent on a two-dimensional echocardiogram, however detailed that is. And some may have a chromosome problem, which we can't pick up on a scan and can only diagnose with genetic studies. One of the points I do try and get across to parents is that surgery can be very successful in helping the children with a single ventricle, but it's not a cure. As well as being faced with a number of surgical procedures, most of the children will be on medication to help their hearts. And this is even after transplantation. Transplantation also in itself is not a cure, it's a treatment, which does require significant input from parents.